Good evening, everyone present here. And today's topic is case based discussion on acute COPD management. Our organizers are Dr. Akhilesh Tandekar, Dr. Gunadhar Pari, and Dr. Asif Iqbal. The examiners we have here is Dr. Rajesh Chawla, who is pulmonology in critical care specialist at Apollo Hospital, Indraprastha, New Delhi. And then we have Dr. Dhruva Chaudhry, who is a professor and head pulmonary and critical medicine at UHS Rohtak. The case presenter we have today is Dr. Anup Gohatre, who is a senior resident at DM Critical Care Medicine at IGIMS Patna. And the moderator we have here is Dr. SANJEEV Kumar, who is professor and HOD Depth of Critical Care Medicine in Indira Gandhi Institute of Medical Insurance, Patna. I welcome all of you today. And Dr. Anup Gohatre, we shall start now.
Thank you. Good evening to all. My name is Dr. Anup Gohatre. I am senior resident at IGIMS Patna in the Department of Critical Care Medicine. Today we will be discussing about a case of acute exacerbation of COPD in the format of case-based discussion. So our patient is a 78-year-old gentleman who is known case of COPD and diabetes mellitus, presented to ER emergency room with a history of fever for 10 days, which was associated with increase in sputum production for last 7 days, and followed by acute onset of shortness of breath for last 3 days. In history of presenting illness, he was apparently all right 10 days back when he developed fever, which was intermittent in nature, not associated with chills, and it was not associated with chills and relieved with medications. It was associated with progressive increase in the sputum production. Over the next 3 days, frequency of sputum production increased further, which was scanty in quantity, thick and tenacious, and more in early morning. It was non-foul smelling, non-blood stained, and no postural variation was observed. Regarding shortness of breath started in last 3 days. Initially, he noticed breathlessness during his routine morning walk. Over the next 2 days, it started hampering his day-to-day activities. And when the patient came to ER, he was not able to speak even complete sentences. This shortness of breath was associated with abnormal breathing sounds, which were not relieved even with increasing nebulization frequencies at home. There were no associated history of chest pain, palpitations, or TND. Significant past medical history. There is history of cigarette smoking, and he was diagnosed as a case of COPD 10 years back.
Okay, manageable. So your time, sir. Can you please present your positive physical findings?
Sir,
let him present, I think.
It's in. This was received from the emergency room, and we examined the patient in ICU. Sir.
Yeah, go ahead, please.
Then there was history of hospitalization for similar complaints every winter during last 2 years, and he was started on inhaled steroids along with bronchodilators, and his diabetes was maintained with oral hypoglycemic agents. At emergency room, patient was drowsy, dyspneic at rest. His heart rate was 110 beats per minute. BP was 110 by 60 millimeter of mercury. Respiratory rate was 30 per minute, and saturation of 86% on room air. Nebulization with leosalbutamol and ipratropium was started in the ER, and 6 liter per minute oxygen given via nasal lungs, and SpO2 rapidly improved to 90%. ABG was sent, ECG and X-ray was done in the ER. In the ER, the ABG came out with pH of 7.32, PaCO2 of 90 milliliter of mercury, bicarbonate of 45 millimole, and PO2 of 62 on room air. His X-ray showed hyperinflated bilateral lung pits with increased bronchoscopal markings, and consolidation was noted in right lower zone. ECG showed sinus tachycardia with right axis deviation, and based on his past history of COPD and symptom and ABG findings, he was diagnosed as a case of acute exacerbation of COPD.
Now, Dr. Anup, patient of COPD, he was a diagnosed patient of COPD. when a patient of COPD present with acute exacerbation, what is the differential? What are the causes of acute exacerbation in such a patient? Or what is the differential in such a patient? Because
Sir,
the problem is everybody makes acute exacerbation of COPD, and these patients have other possibilities also, which must be thought of rather than jumping onto the what are the others you must examine. You may not have, when a patient presents, you presented the whole thing. Suppose you don't have investigations, patient has just presented in the emergency. Just go back one slide where the investigations were not there. So let's see here. So what are the differential till this time?
sir, if any patient who is known case of COPD and presenting with acute onset shortness of breath, first we must rule out the possibility of pneumothorax, because of the COPD patients are often have bully and inflated lungs. They are at high risk of developing pneumothorax, and it is life threatening. So we should exclude that possibility. Followed by there is possibility of RV failure or heart failure.
That is why it is important when a patient presents, you must describe the examination in detail so that in that it is obvious to the examiner that there is no pneumothorax.
Yes, sir.
Just like saying that these sounds are there, because many a times, even if there is a pneumothorax, the examination doesn't tell in these patients. Many of these patients are silent otherwise also. An acute exacerbation, they are even more silent, and you hardly hear very minimal of breath sounds. So that is one pneumothorax. What else?
Another possibility is the right heart failure or heart failure, sir. As these patients are mostly old age, and because of chronic COPD, they have a ongoing chronic pulmonary situation, which can exacerbate with any stress induced, any kind of stressor. And
Right.
another is they are at high risk of DVT and pulmonary embolism, which can also present as sudden acute onset shortness of breath. So these are the
Sir, this could be pneumonia also, pneumonia or acute
You
bronchitis.
can drop the question in the chat box. Don't interrupt like that, please. And we
these
will
are
take
the
your question.
Yes, let them present.
So these are the life-threatening condition which must be ruled out at first contact. Then other mimics of acute exacerbation of COPD can be pneumonia, like there can be a pneumonia without exacerbation of COPD condition, or there can be pleural effusion, or
So these are, there are three conditions which I think all of you must think of. Any patient presenting in acute exacerbation, because they are missed and sometimes can be disastrous. Of course, pneumothorax, as you said, heart failure, pneumonia. These are the three important conditions, and very common as well. And then, of course, pulmonary embolism as well. Probably once you've ruled out these, because these are common. Patients, the pneumonia is common, the heart failure, because of their, as he said, there are possibility of heart failure because they are in that age group, and many of them have right heart failure already in existence, and copper what you call. And the other, what is copper doctor?
cor pulmonale is a term which describes the onset of heart failure or cardiac disease secondary to pulmonary disease.
No, how do you define copper
If there is chronic ongoing pulmonary pathology which will affect the pulmonary vasculature, and because of the
There is a
increasing
right ventricular enlargement.
there will be chronic right ventricular enlargement associated with right ventricular
Secondary
dilatation.
to disease of the respiratory apparatus, which could be lungs, which could be chest wall, and then that you call it as a copper and present as a right heart failure. So, whenever the patient is there, don't jump at a diagnosis. It is just an acute exacerbation of COPD. Or, acute exacerbation of COPD can also occur because of these causes. So, whenever a patient has a breathlessness, you should think of pulmonary embolism, pneumonia, heart failure, pneumothorax. Because if you miss any of these and you are late in treating, the outcome in your patient may not be good. So when do you say it is acute exacerbation?
When there is acute onset shortness of breath along with increase in symptoms of routine symptoms like cough, sputum production and dyspnea, uh, which which leads to hospital visit and increase in medications dose or addition of medication, it is labeled as acute exacerbation.
Right.
Good evening, Dr. Chawla. Good evening, everybody.
Yeah.
I was listening carefully. You
Yes,
see,
good morning,
when
sir.
you're talking in terms of good evening, Sanjeev, good evening, everyone. You see, there are a few fundamental things I think you have asked Dr. Chawla, quite a few of it. I do not agree at all that if somebody has a core pulmonary, you will label it as AECOPD. Most important component is that this is the group where you tend to have left heart failure. That can present as a worsening breathlessness, or that may present then you think in terms ACOPD or any hypoxemia can worsen already existing right heart failure or corpulmonal patients. And when you define corpulmonal, you need to be very careful. It is secondary to pulmonary arterial hypertension. You may or may not have evidence
Heart
of failure
failure.
along with it. So primarily it is a pulmonary hypertension happening secondary to, as Dr. Chawla said it, any disease related with the lungs, any disease related with the chest wall, or alternately in some conditions also, few conditions where you can also have a subclinical capillary damages that lead to pulmonary hypertension. So it's very fundamental when we talk about it. And when you say pulmonary hypertension, it is a class 3 WHO, where you will have a COPD associated with it. Secondly, when you talk in terms, very rightly, Dr. Chawla asked about it, and you did mention about pneumothorax, that is one part. And along with it, most important, the moment you label somebody as a pneumonias will not be considered as a part of ACOPD in a purest form. Loosely, yes, we put it up together, but if you really look at it, pneumonias usually tend to, when you exclude all these things, whether pulmonary embolism, which is rightly you have said it, they have increased evidence of vasculopathy. You have an evidence of left heart failure, which can come up, cardiac failure. That is what will define it, not the right sided. Right sided will come up, cause elevated JVP and edema that can worsen with hypoxemia because of worsening pulmonary hypertension. But that will not be ACOPD. That will be very, very clear to everybody. And along with it, if you're finding any pneumonias, then it will be pneumonia with obstructive pulmonary disease. So classical pattern of acute exacerbation of COPD, you will not routinely in plain radiology will find any evidence of any other disease except the existent disease which get worsened. That's how we define it. That's what the gold talks about it, and that's what we do. One. Secondly, when you're
Dr.
writing
Dhruv,
about these examinations,
yeah, can I interrupt? You see,
yeah, please.
one of the reason for acute exacerbation is infection. So I think one should, what Dr. Dhruv is saying, if you see a consolidation, if you see that is a pneumonia, but these patients, one of the common reasons they get acute exacerbation is infection, the lower respiratory.
Agreed, but their viral infection, they
So,
will have a dominantly
bacterial as well.
tracheobronchitis.
So,
You will have a low respiratory tracheobronchitis, viral induced. It can also be induced by pollutants. It can be other factors. But classically, if you see radiologically a consolidation, in pure form, I'm saying, we treat it as that way within this thing, but in a pure form, then it takes you away from it if you all the classical definitions. So it's very fundamental to understand when you talk about acute exacerbation of COPD. Viruses, as Dr. Chawla very rightly said, infection is the commonest cause. You can have a influenza, serach influenza. You can have it. You can have viral influenza. So you can have all these things. So for us, it is important to understand. Similarly, if that is why we get an anti-pro-BNP, that doesn't mean that the right heart failure. You are looking at the left heart. So it is very important for us to evaluate the left heart. Right heart evaluation is important. So that's the fundamental thing which we need to look at. Pneumothorax, you very rightly said. What is the difference on clinical evaluation between acute exacerbation of COPD and asthma? So can you tell me, Anup, how you differentiate?
Sir, in pneumothorax, there will be unilateral absence of sound on chest auscultation, whereas in COPD, there will be wheeze bilaterally, and air entry will be present bilaterally. And
Any
in
echo
pneumothorax,
finding?
on echo, or if you do lung ultrasound, there will be barcode or barcode sign present on the unilateral side of pneumothorax. We can also find the lung point on the side of pneumothorax, whereas that it will be absent in the COPD. And pneumothorax, if becomes tension pneumothorax, there will be evidence of shock and hypotension clinically.
Anup, again, I am interrupting it. You see, when we are talking in terms of, it's a simple question which we always ask. How you differentiate between ACOPD and acute exacerbation of asthma, acute severe asthma? That is fundamental. You said wheezing. How many percentage of the patients of COPD you auscultate wheeze?
I thought that you are asking about difference in COPD and pneumothorax. In while differentiating between ACOPD and asthma, asthma will get the onset will be in younger patient in asthma, whereas COPD will be patient will be older age group because of the progressive nature of the COPD. The wheezing or the airflow restriction will resolve with bronchodilator rapidly in case of asthma, whereas in COPD it will be irreversible.
You see, again, that is what I am saying. We all look at investigations. Clinically, when you evaluate these cases, I hope Dr. Chawla will agree with me. In COPD, primary finding on auscultation is decreased airway entry, decrease in hyper, because lung is hyperinflated from all that. Wheezing will be seen in less than 50%. Whereas when you look at an asthma, normally sounds are very crisp. There you will see much more in terms of evidence of a wheezing, one. Secondly, because acute severe asthma, you tend to have a reduction in the intensity of sound. That's why silent chest is a hallmark of acute severe asthma in its severest form and is a danger sign. Whereas in patients of ACOPD, because there is a significant hyperinflation, most of them are a combination of both bronchitis and emphysema. So you don't have that issue. Thirdly, when you start to, you have rightly said it. Now here you have shown it very clearly that in these patients, when you see drowsy, dyspnea at rest, etc., majority of these patients will be, if they have a dominantly COPD, they have a phenotyping. You can immediately get it up. Common, you will tend to see a blue bloaters, but you can also have a pink puffers, which are dominantly emphysema, will be there. And when you are talking about it, which you have rightly said it, you see, we used to define earlier in the severity pulses, paradoxes, etc. You did talk about it when I was listening carefully. Person can speak in words, sentences that define the severity. But when you're looking at the COPD asthma, there can be an overlap, and you are right that majority of the time in COPD people will be more than 40. But at the same time, there are a number of other conditions which are airway, which can happen in younger, and when they go up, they behave like a COPD. Phlegm production is one important aspect. Similarly, as you're talking about, a number of these cases also tend to have a problem clinically in diagnosis with the heart failure. And I have seen people giving them morphine, etc. So there you have a retention secretion, coughing, etc. So you need to look at it, differentiate, and pulse there becomes very important. In patients who have a left heart failure, you will have a pulses alterance, you will have a thready pulse. Here you will have a bounding pulses in patients of COPD because of CO2 retention, and there will be a lot of perspiration and sweating. Dr. Chawla must have seen quite a few cases which we see in emergency, and people tend to sometimes make a diagnosis of left heart failure. So you need to differentiate these things very, very clearly and lucidly. That is why in the old time, when we didn't have this much of a finesse, these problems used to happen. And as you have also shown in this particular case, please do mention whether there is excess work of breathing or not. And for that, you have nowhere in the findings written whether accessory muscles of respiration are working or not. That means whether you sternocleidomastoid, whether you have an intercostal indrawing, is possible or not. In patients of COPD or severe asthmas, whether they can lie down straight or not. In asthma, if somebody cannot lie down straight, it's a very ominous sign. So these things you need to describe us all the point of time which is there. And another observation which is there in emergency is that you have written 6 liters per minute of oxygen with nasal prongs. This can be extremely dangerous. It's a very high level. And I need to ask you why, what happens when you start giving more than 2 to 3 liters of it? And the dictum usually is that if you have got more than requirement of 4 liters in the acute exacerbation, look for an alternate diagnosis beyond ACOPD. In any case, which we have already talked about, this patient having pneumonia. So can you tell me what can happen if you use nasal prongs, and what should be the primary mode of oxygenation in these cases if you suspect?
Sir, giving excess of oxygen in these patients may worsen the hypercapnia. As earlier, the theory was given as a because of the chemoreceptor in the carotids are sensitized to lower level of oxygen. If you give hyperoxia, the respiratory rate will go down. But the newer theories are suggesting there is worsening of shunt because of abolition of hypoxic pulmonary vasoconstriction, and as well as because of Halton effect, oxygen will bind more to the hemoglobin and more of the CO2 won't get expelled out.
What is Halton effect?
At the lung, when we look at the O2 at the site of lung alveolar level, more in the presence of more of the oxygen tends to bind more avidly compared to CO2, and CO2 will not release out.
What is Bohr effect?
Bohr effect occurs at the level of tissue level, where because of the presence of more CO2, it will bind to hemoglobin and oxygen will release there in the muscles.
Sure, Dr. Chawla, please.
Yeah, no, I mean, I think the thing to stress is that when you examine these patients, because acute breathlessness does not mean it is just a COPD acute exacerbation. You need to ask the previous history also in detail, any comorbidities, because that will help you that whether you are dealing with the cardiac component or the predominantly the lung component. This is extremely important. And I think as we have discussed in last 10-15 minutes, that you must keep other differential diagnoses before jumping onto this, because if you delay pulmonary embolism, if you've not examined the leg for looking for DVT, or if you not make a diagnosis, then the results would not be, and you would think that probably the COPD exacerbation did not respond and patient had sudden some problems. So this is very important, not only from the exam point of view, the otherwise also when you're dealing in your clinic. And I think the most important thing is that these patients they can tolerate low oxygen. You always remember, sometimes these patients walk into your OPD and they're having 70, 80. And if you try to correct it, they may land up in an invasive ventilator. I still remember that when we were very young, people were given oxygen 3-4 liters, and they were on, not only on that time, non-invasive was not there, people used to go on a ventilator. So you need to be careful. Of course, you should titrate to SpO2 between 88 and 92. But then you have to be extremely careful because you can't be there all the time. So better is to give a lower oxygen and see where you can just reach 88. Because as the bronchodilators and others you give, the person's oxygenation is going to improve. And particularly if you're not using the non-invasive ventilation. If you are using non-invasive ventilation, then probably you are a little safer. But if you're not using, you need to be extremely careful about giving oxygen. And another thing which I want to ask you is, how do you give nebulizer in these patients, and what is the dose you can give? And if you do not have nebulizer, can you give the meter dose inhaler, and how much you should give?
Sir, regarding the nebulization, regarding the sir asked what is the preferred modality of giving oxygen. So it should be preferably given via venturi device, so we can titrate the FiO2 more precisely. And regarding nebulization, driving gas for nebulization should be air rather than the oxygen. so that we don't give excess of oxygen. And metered dose inhaler with spacer can be used in this patient if they are cooperative and they are used to their use.
Sir, from the clinical perspective, if you see it, you have written at emergency heart rate. What is the blood pressure? 110/60. That itself tells you, if you really look at it, that normal blood pressure, normal pulse pressure is around 40. It's on the higher side. So these are the small things when you start evaluating clinically, especially when you have a CO2 retention, that lead to very significant these vasodilatations. And early morning headache is again one of the very important signs for patients of COPD with having a carbon dioxide retention. So what Dr. Chawla was trying to emphasize is, and I hope he will agree with me also, is that we need to take a comprehensive history along with examination, and that will give us a lot of clues what is happening. And obviously, one clue which will always give you in the clinical history about pneumothorax is sudden onset breathlessness. When AECOPD happens, it takes some point of time to build up to that momentum. Pneumothorax will be sudden worsening which will happening, and there may be a pain on deep inspiration. As far as the pneumonias are concerned, you will tend to find history of viral infections, and also along with it, there will be a pain or there will be a sputum, which could be rusty color, or there will be a bug in that. So all these things we need to be careful. So history, as has been pointed out, is the key. I think let's move ahead and go ahead with it.
Just
because
one
I
question.
think, yeah.
Somebody's asked also, sometimes these patients, if there is a very large, not classical pneumothorax, and you find an area, whether it is a bulla or pneumothorax, and you don't have CT available right at the moment, patient is sick, he cannot go to the CT. How can you differentiate? How will you differentiate that it's a pneumothorax or a large bulla? First thing which will really give you immediate clue that yes, that I am dealing with this.
If there is hemodynamic instability with that much large bulla, we can if there is hemodynamic instability, we can assume that it is a pneumothorax. But ideal way is
it could be an infection also in that patient, so that may be causing. You see, the first thing, the answer which I wanted was ask for a previous X-ray, because many times just looking at the previous X-ray will tell you that it is going on. This is a clinical. I mean, many a time just looking at the previous X-ray you can make it out. If it is not there, or otherwise, what else can you do to differentiate between these two?
We had one similar case where outside, the pigtail was inserted inside the pneumothorax, considering it as pneumothorax, and there was bulla on the other side. We searched the literature but couldn't find any definitive way to differentiate both. There was some
really very
ultrasound.
difficult, but you can.
That is exactly Dr. Chawla is asking, my dear. Answer to that are, you see, ideally CT, okay, it's not there, you can't send everybody to do that. Answer is very straightforward. I would have expecting you to do that. We always do X-ray chest PA view. Practically, if you read all the books of pulmonology, and I hope again Dr. Chawla kenge, they always recommend two views, PA and lateral. That will give you a fair amount of unmatch. Secondly, whenever there is a pneumothorax, you need to see the lung tends to collapse towards the root. That is the hyla. And you will see it, there will be convexity outward. Whereas in the patients of blebs, you will see concavity inward. So you will find it out that there is no as such areas marking, sometimes you can see through it. And finally, today, if you have a proficiency in ultrasonography, which you started talking about it, it can help you, because when you are looking at it, it doesn't fit with any of those profiles. The normal A profile which comes up, and there is an exacerbation and there is no evidence of DVT, you think in terms of, or PE, you look at AECOPD. There it can help you in differentiating partly to an extent whether you are dealing with bleb or you are dealing with the pneumothorax. Pneumothorax, as you were talking about, that there will be like you do a 6 flaps and then you see and find it out. But definitely answers will be there, but it is always better that when you are seeing it finding it out. And there's sometimes ECG changes, though they are not very specific, they tend to happen also with pneumothorax. So there can be multiple factors, but on the bedside, for me, the best thing are only two things: X-ray chest, you will see a lateral view with the PA view, and also along with it, as Dr. Chawla said, ask for the previous X-rays. And thirdly, today a lot of people will have on your mobile phones. And finally, ultrasonography on the bed can differentiate with the sensitivity and specificity of nearly 90%. Do you agree, sir?
Yeah, I think so.
Yes, I agree, sir. But in ICU, lateral view is a little bit difficult to take. So,
It's not,
but
it's, you see, it's
So
not
with
that.
a
Most of
mobile,
the
they
time
can
we are
take.
not, most of the time we are not used to that. Problem in the
yeah, yeah,
ICU is that you don't take PA view, you take AP view. Therefore,
yeah.
sometimes you can have challenges, but that is where the expertise is required. And another way you can do simply is in the intensive care unit is, if somehow, if people can hold a little in the expiration, then it can pick up. Then on the top, you can easily see. And finally, it is very important in radiology. I think, Dr. Chawla, you always see it, finding it difficult when persons on ventilators. How you find out that you have to see is a dipping of diaphragm down. Then you also need to see deep sulcus sign. All those things starts coming into picture, which you need to see. But lateral view, standard pulmonology teaching, ideally is that we should have a PA lateral view.
Sir, meanwhile, can I ask one question? So, sir, which method of nebulization is preferred in a case of AEC COPD? Can we use mesh nebulizer or a jet nebulizer? Which one is more efficacious?
See, the mesh nebulizer are the better one if you have the available with you. But otherwise, you can use the jet nebulizer also. But if they are available, mesh nebulizers, they are very quick, good, effective. So they are preferred. Now we use mostly mesh nebulizers. And but since they are little expensive and you can't, we don't use from one patient to another the same nebulizer kit. But I think the mesh is better if the question is that. People have asked few questions. So
Uh,
how long shall we keep patient on non-invasive respiratory assistance if patients are in severe COPD but not life-threatening? It is not about the time we keep the non-invasive respiratory assistance. It always depends whether patient is responding or not responding, or patient is worsening. If patient is getting better or remains the same and he's not once worsening, sometimes it take many days for patient to respond. But if patient is worsening, like patient who was hemodynamically stable, was conscious, and now he's becoming drowsy and is hemodynamically unstable, he can't protect his airways, he's getting tired, he's exhausted, then you can intervene. Time is not an issue. It is always the trend, which trend patient is going when you say that now you have to stop non-invasive and go on to invasive respiratory assistance.
You have acute type 2 respiratory failure, which was leading to altered mental status. Patient was shifted to CCM ICU. So these are the definitions. Sir, should I continue with a definition or only case?
No, we'll just discuss the various issues related to the case. Go back, please.
So that was the definition.
I said go back, not the literature. All of them can read. This is acute access. How did you manage this patient?
Sir, as we first gave the NIV trial to this patient because of it is hypercapnic acute respiratory failure, and PO2 was not that much of an issue. We gave the NIV with face mask and to start with, and simultaneously we started evaluating the cause for his exacerbation, which came with lung ultrasound. I have the clips of the ultrasound. With lung ultrasound, we could find the hyperdynamic air bronchograms in the left middle zone, and as well as there was some atelectasis and pleural effusion in the left side of the lung. So we even presumably assumed that the cause for this acute exacerbation was pneumonia. and we started on him on we followed the 1 hour sepsis bundle started with the broad spectrum antibiotics and gave the fluids as per the status of IVC and heart, and sent the culture, sputum culture, as there was a sputum initially, and along with blood culture from two sides. And there was a short episode of hypertension which we started managed with noradrenaline infusion.
No, you know, when you are presenting such a case, I would like to know the day-wise detail, the COPD and everything they could have read. You know, anyway, now let me ask you questions. You said you started on non-invasive ventilation, and this patient presented with breathlessness for how many days?
It was for 3 days.
3 days. And his pH is already corrected. His PaCO2 is high and bicarb is already retained. So you think this is an indication for non-invasive ventilation? What was the indication of giving non-invasive ventilation to this patient?
Sir, there was signs, means increased work of breathing was there. He was using his accessory muscles, and rapidly he is going to fatigue. There were intercostal draining and paradoxical breathing with use of abdominal muscles, and all this was leading to fatigue, and
yeah,
he may eventually land up into acute respiratory failure. To prevent that, as soon as the patient arrived, we started on NIV ventilators.
So what are the indication you feel when do you put a patient on NIV in acute respiratory failure in COPD?
If pH is less than 7.35 or there is hypercapnia along with acidosis and increased work of associated with increased work of breathing, and if there is no contraindication for NIV.
So what are the contraindication of NIV?
If patient is not conscious and not conscious oriented and not cooperative, if there is absence of reflex, he may aspirate, and if there is any facial trauma or associated other relative contraindication like claustrophobia or injury, facial injury. And if there is impending respiratory or cardiovascular arrest, we should straightforward go to invasive ventilation.
So what does the literature say about the indication of NIV? I mean, every patient of COPD who present in acute exacerbation, you will put on NIV.
No, sir. Moderately ill, or if they are not in immediate need of invasive ventilation, to elevate their work of breathing and help them breathe smoothly, we can put the NIVs.
You see, the contraindication of NIV are like if patient is hemodynamically unstable, he cannot protect his airways, you cannot fix up the mask on the face of a patient, and if there is a vomitus, these are all contraindications of NIV. But NIV is your first source. And when do you put it? You know, the literature says that if it is less than 7.35, then you can give non-invasive ventilation in addition to the your medical management, because first your medical management has to be proper. And when you give it, because either of these, either the patient has acute respiratory distress, or there is a hypercarbia, or there is a PO2 is low, you know, if any of these two conditions are present, or there is abdominal paradox, you can give NIV to a patient of COPD. And what are the indications of converting it to an invasive ventilation?
After putting on NIV, indications for converting it to invasive ventilation is there is one validated score, HACOR score is there, where we assess heart rate, acidosis in the form of pH, C for consciousness in the form of BCS, and O for oxygenation PF ratio, and R for respiratory rate. If it is more than or equal to 5 at the end of in the initiation or after applying NIV for 1 hour, it is an indication for NIV failure, and you should switch over to invasive ventilation. Along with that, if the patient become unconscious over the NIV and cannot protect his airway anymore, or there is vomitus because of raised intra-abdominal pressure and patient is vomiting and there is risk of aspiration, and worsening hypoxemia even with NIV, and worsening hypercapnia and acidosis even with the help of NIV, we will switch over to invasive ventilation.
The indication of invasive ventilations are just three. Number one, there is a contraindication of NIV. You cannot give NIV, you go on invasive. NIV is failing. Patient respiratory failure is not responding to NIV. And the third is that patient does not tolerate. There are very few patients who would not tolerate NIV. They are very sick, they're drowsy, you know that you can get over, and they will not. Otherwise, when you cannot give, or it is contraindicated, or it is not effective, so then you do invasive ventilation. The first choice of ventilation in a COPD patient is non-invasive. So when it is failing or contraindicated, patient doesn't tolerate, then and among the contraindication, all those conditions will come, like the altered sensorium, hemodynamically unstable, all those things. And failing, when patient is deteriorating, patient is getting exhausted, patient is going into shock, then you convert into a invasive ventilation. So when you ventilate a patient of COPD, what are the extra precautions you take when you ventilate these patients?
Invasive ventilation.
Yes.
During invasive ventilation, while intubating the patient, we should choose the maximum bore of ET tube that is possible for better suctioning, as well as reducing the external means maximum caliber should be there.
For an adult male, which number of tube you will prefer?
If I will go with adult male with well built, I will go with 8.5 millimeter of
8 or
IT.
8.5, right? And what kind of intubation you will do in these patients?
The rapid sequence intubation, if there is impending respiratory arrest, I would.
What do you mean by rapid sequence intubation?
I will give means without following all the steps of intubation, means like sedation and then analgesia, and then followed by hypnotics and anesthetic. I will give rapid onset of inductive agent, followed by quick onset of succinyl coring or rocuronium, which has short, very rapid onset of muscle relaxant, and followed by I will use bougie, and ET tube will be passed into the trachea.
And what kind of settings you will do in these patients?
Initially, I will put as the patient is relaxed, I will go with volume control ventilation with FiO2 titrate to 88 to 92 of SpO2, and respiratory rate will be from around 10 to 14 or 12 per minute. And I ratio, I will choose lower side of the I ratio, means 1:3 or 1:4. And tidal volume will be maximal possible, means around 8 ml per kg of ideal body weight. And I will choose to give the breath very faster. I will choose the high inspiratory flow rate, and the expiratory sensitivity will be as longer as possible.
So,
To 75%.
basic principle in these patients is that you use, most of the times in these patients, you can use the volume control, keep a lower rate and lower tidal volume, 6 to 8 ml, 10 to 12, give a minimal inspiratory time. That means I ratio should be less, like inspiration is less and expiration is more. Higher flow rate, 60, 80 sometimes, and you have to fix up the peak inspiratory pressure alarm, because if you do not put a peak inspiratory pressure alarm high, then your breath will get cut off, because when you give a higher flow, the peak pressure is going to be very high. If there is a spasm, and the patient will not get. So you have to fix up that little higher in these patients. And then, of course, the rest of the treatment should continue. We did not discuss much about the rest of the treatment. So what is the basic components of management of acute exacerbation? Once you've ruled out there is no failure, there is no pulmonary embolism, there is no pneumothorax.
Confirming the diagnosis, first thing is to identify the precipitating cause and treat it. Second is to maintain the proper oxygenation and acid blood acid level acid base levels in the blood. And third is to other supportive avoid the bronchospasm and related microventilatory ventilator related complications. And next is other management like nutrition and other cares.
No, I'm asking about antibiotics and steroids, which you have not discussed much about that.
And
Steroids, why steroids are given in these patients, and what is the evidence behind is using in a severe acute exacerbation of COPD?
So the management of ACOPD, the first line therapy is short acting SABA and SAMA, the bronchodilators, and the steroid inhaled or IV can be given in acute exacerbations. The basis
Inhaled is
for
different, IV is different. IV, what is the dose of IV steroids in these? And what
1
is the
mg per
equivalent
kg of
oral in these patients?
50 mg of 1 mg per kg of methylpred IV.
You
And
can give actually 40 to 60 milligram of prednisolone or equivalent dose, but most of the people you go around, they give hydrocortisone twice or thrice a IV. That can also be done, but usually they say about 60 milligram is good enough. And when will you choose? And they should always be given in a moderate to severe COPD exacerbations. And antibiotics, how will you choose antibiotics in these patients? And what are the commonest organism or the viruses which cause acute exacerbation?
the most common viral infection is rhinovirus or respiratory syncytial virus, and most common bacteria are Moraxella, influenza, and other organisms of cap, staph and step 2. So based on
Which
that,
is the commonest bacteria which causes acute exacerbation? Not the
Streptococcus
Moxella.
pneumoniae.
Which is the commonest bacteria I'm asking?
Streptococcus pneumoniae.
Yes, correct. H. influenzae, Streptococcus pneumoniae, these are the common. And when will you think of, and what is your drug of choice in these patients?
So for this patient, we should start with ceftriaxone as along with one respiratory fluoroquinolones for atypical coverage.
And when will you think of giving anti-pseudomonas cover?
If there is associated airway disease or like ILD bronchiectasis, anatomical disease of the airway, or there is a previous hospitalization report shows that pseudomonas was growing in this patient's sputum, and then we can consider adding anti-pseudomonal to this.
Yeah, that is correct. There are 2-3 things which you must keep in mind. Structural lung disease. If a person has bronchiectasis, there is structural damage. He's an old cox and he's been in and out of the hospital, or there is a report which is carrying pseudomonas, or he's on a chronic steroids. These are the risk factors for pseudomonas. And then what would be the choice of antibiotics if you have to give anti-pseudomonal community-acquired infections?
Based on our local antibiagram, we can select starting from BLI like piperacillin, tazobactam, or carbapenem. If there is high resistance of carbapenem, we can go to polymyxin and anti-pseudomonal antibiotics.
And okay, and then what are the other supportive care you give to these patients?
Supportive care, there should be frequent suctioning whenever needed to remove the sputum, or if there is any source is there, we should control the source. We should give frequent bronchodilators and inhale steroids. Also, in physiotherapy there is very important role of physiotherapy in increasing the expectoration or clearing the respiratory secretions. And nutrition is important aspect in COPD because there will be pulmonary cachexia in chronic COPD patient and their old age. And that's all I can.
And nutrition.
Yes.
The nutrition which we forget, we should take care of nutrition. electrolytes, pH disturbance. The other thing is, which we commonly see many a times, people give a lot of diuretics and they become metabolic alkalotic. They have recovered and they are looking weak and drowsy. You must look for this and correct it with adequate amount of fluids if they are dehydrated.
Yes, sir.
So,
with rapid correction of CO2 also, there will be metabolic alkalosis,
you
post
were talking
hypercapnic
about
metabolic.
pulmonary rehabilitation.
Yeah.
So what is pulmonary rehabilitation? We have just 4-5 minutes left. So
I'm not sure of the answer, sir, but maybe pulmonary physiotherapy and training the patient regarding proper use of inhalers and
okay, now we've
pyrometer.
discussed everything. Let's come to weaning because we had put patient on invasive ventilation. So what are the criteria of weaning in COPD patients?
First of all, like any criteria for weaning for any case, there should be reversal of the indication of intubation. If in this case, as it was a
The
pneumonia,
primary reason for which you had ventilated has been cured. So you
start giving
that is number
spontaneous
one,
breathing trial.
starting. Like there was infection, there was pneumothorax, whatever was there, you've taken care of. Okay, now
Then there should be acid-base correction. CO2 should return to the baseline, and pH should be normalized.
do you bother about PCO2 or you bother about pH?
pH should
So
normalize.
don't say, because you see, everybody talks about PSU. It is the pH. Always ventilate a COPD patient to pH, not to the PaCO2. Patient many a times come with 60, goes back 65. So that does not. So it is the pH correction. pH is patient acid mass is showing compensated, respiratory acidosis, oxygen is corrected. What else? And there are no other, all the other criterias of weaning, like the electrolytes are normal, the patient can engage, patient is off sedation, patient, I'm sure the patient was not on paralysis.
Yes.
Then the hemodynamically is unstable or is in a very minimal of NORAD support. So these criteria are there. So what will you do now?
I will give the spontaneous breathing trial. I will put patient on pressure support ventilation. And
The spontaneous breathing trial has failed. Patient, you put on a T-piece or you put on a pressure support, patient is breathing at a very fast speed, and although your basic primary reason for which you ventilated is corrected. So what are you going to do now?
then
You
I
know
will
about NAVA trial in non-invasive ventilation?
now a trial. I am not aware.
NAVA trial was one of the initial trial where they showed that you give a spontaneous breathing trial. If it passes, you extubate the patient. Even if you fail, if your primary reason is corrected, there is all indications for weaning, then you extubate these patients and put a non-invasive ventilator. And you are going to, that is what we do most of the times.
Yes, sir.
If you know that you extubate these patients quickly and put them on non-invasive ventilation. This is one condition where in weaning, in COPD patients, non-invasive ventilation has been found to be extremely useful and helping in early extubations. And as for the pulmonary rehab is pulmonary rehab is basically a multidisciplinary. It is not only the physiotherapy. It is the occupational therapy. It is the respiratory, the nutrition. All these components are part of the pulmonary rehabilitation. So thank you very much, Dr. Anup. You did well. And Sanjeev, back to you
Yes, sir.
for your
Yes,
comment.
sir. Yes, sir. Thank you, everyone, everyone for participating this thing. I think Anup has nicely presented the all aspect. He covered the each and every aspect like differential diagnosis and all the treatment modality. And you are rightly said that it should be covered as a multi-modality approach because it is not covered only by the simply physiotherapy and the each and every even nutrition is the one of the most thing and I personally feel that in such situation most of the time our residents do some mistake that they give more and more oxygen and they ultimately landing in the problem. So we should keep in the mind that such patients should we should avoid excess oxygen, and we should know that when we have to put such patient on the non-invasive ventilation, and when we have to intubate such patients, and so appropriate timing is one of the critical thing that we should know. So since
Dhruv sir want to say something. Good
yeah,
evening, sir.
yeah, Dr.
Ashish,
Asif.
thank you so much.
Yeah,
Sorry, I had to in
yeah,
between break away because my director
yeah.
called. You see, though I was hearing it, not as
Mm,
carefully listening. Couple of 2, 3 quick points for the residents who are presenting it. One
mm,
is that these patients have a significant issues related not only with the airways, but as a consequence, there is a lot of muscle dysfunction, diaphragmatic and all. So 1 or 2 drugs which are very useful in this, though people don't use it quite often. One is a levosimendan and another is a aminophylline. Now, levosimendan is not usually there. You can use either of them to improve diaphragmatic contractility. One. Secondly, if you use small dose of aminophylline in it, it also has a mucociliary function. And secondly, it has a secondary diuretic effect. So it can improve cardiotonicity. And the only thing you need to be careful is it has a very low therapeutic index, and people sometimes can have a nausea, vomiting, and all. So we use quite extensively in these patients to facilitate weaning when we find difficulty. Point one. Second is the another drug which has really come up and helping us in acute exacerbation of COPD, though the conventional wisdom is, and again the guidelines and directions are to use SAMA and SAMA. But today, with the glycopyrronium, again is an additional drug which is coming up along with the formoterol. You can use these 2 things together. Third is that number of these patients had underlying chronic coronary artery disease. So in winning, if they are not doing it and repeatedly they are going into a trouble. So please do look at it. CAD, heart, you must look at it. And that is where you would probably will be required small dose of sorbitrate, plan it up and take them off. Rest of the part in terms of nutrition, in terms of therapies, physical rehabilitation, occupational, Dr. Chawla has very beautifully highlighted that. And finally, I think which is very important is this in these patients is do not hesitate to use NIV in extubation, and also in these patients supplemental high flow oxygen can be used. We did one study, we will be sending it for publication. Usually we tend to avoid as far as possible high oxygen, but high flow oxygen in acute exacerbation sometimes can be useful, but it is one place where NIV is always preferred over high flow. So another thing which can happen is Dr. Chawla will also probably, sir, you will say is if person is a little obese, please do rule out overlap syndrome of obstructive sleep apnea. I think that is very fundamental, which can happen with these cases. And somebody has written a question that is where tracheostomy you may have to need for some point of time. These are the few things we need to be careful. Additionally, somebody has also written role of anticoagulation. Anticoagulation, vasculopathy, systemic as well as pulmonary, both are known in these cases. Depending upon the criteria, if you can use a physical activity of the lower limb, nothing to beat it. But if yes, there is a problem, you should use low molecular weight heparin as part and parcel of it. AOCOPD, mucociliary technique, cuff techniques are very fundamental, very important, and that is what we need to ensure it. And one more point is one has seen in the general practice people quite often using drug which is called as acetazolamide. Acetazolamide, we can use it in this condition, in those conditions where you find there is a marked metabolic alkalosis, because you are using steroids sometimes, quite often because of pulmonary people do use diuretics that all lead to metabolic alkalosis, and that can create a trouble in weaning. So that is one place where you can use acetazolamide, keeping 2 things: there is no hypokalemia, and secondly, there is no sulfur sensitivity. If you can take care of these things, that is where you tend to have a lot of bicarbonate urea, which is caused and can help you retaining back. The second drug whole time which people use and we rarely use in intensive care units in weaning, etc., or where we either respiratory stimulants. Routine, it is not recommended, neither needed or required. In a small subset where we're finding there is a problem, there you may use medroxyprogesterone or modafinil. Not otherwise, not in a routine, is not recommended in a very small subset of patients. This is what is needed and required. That's what completes the full medical management of patients of acute exacerbation of obstructive pulmonary disease.
Somebody had asked this question. If patient is not getting weaned off from NIV, then you can send him home also on NIV, and you must evaluate after a few weeks whether there is any indication for home NIV, because there are studies to show that it does prolong survival. But I think immediately for a few days you can give NIV at home also.
Sir, I extend to that few days to up to 6 weeks you can use it and then decide. Please never prescribe NIV and long-term oxygen therapy on discharge. When you are giving it is a continuum of AU COPD. For long-term oxygen therapy, you need to define it after 6 weeks when everything stabilizes. Prior to that, no home therapy, etc. For long-term, what Dr. Chawla said, we will follow it up. We do prescribe, sir, for 3 to 4 weeks home new NIV. After 6 weeks, we reassess and then we take a call and then go ahead with it. And one set you can do on the bedside and train them. Physical rehabilitation is not 6-minute walk also. People can do a 2 shuffle testing or sitting on the chair, getting up, sitting on the chair, getting up. Idea is to put the cardiorespiratory one, but please do a good cardiac assessment before you tell these physical activities. I hope that you agree with it.
Medroxyprogesterone, role of medroxyprogesterone.
Sir, I have already talked about it, medroxyprogesterone.
But how does it act?
Now the action of it is, this is a respiratory stimulant. Basically progesterones, they work on the respiratory center. That is why I use the word modafinil. So they try to stimulate. These are the respiratory stimulants. अगर आपको याद हो डॉक्टर चावला पहले निकेथामाइड भी यूज हुआ करती थी, which has been stopped altogether, and NIV. So 2 drugs are there for respiratory stimulation. One is your medroxyprogesterone and second is modafinil, and the other drug group is, which I have already talked about, acetazolamide. Acetazolamide
Dr. Dhruv, this modafinil, it is quite a useful drug in the ICU, not only for COPD, for residual drowsiness. Sometimes everything is corrected, but because of prolonged illness, electrolytes are correct, the ABG is correct, still there is a relative drowsiness. These drugs are extremely useful in COPD, in others patient also. But always remember that if you give a high dose, they have a seizure tendency. So you need to be careful in these patients. Otherwise, pretty safe drugs.
सर अगर आप देखेंगे प्रेगनेंसी में प्रोजेस्टेरोन लेवल हाई होते हैं तभी वो रेस्पिरेटरी अल्कोलोसिस होता है, तो वो है। इसी तरह से जो मैंने एसिटोजोलामाइड बनाया कि जब आपका व्हेन यू हैव टू मच ऑफ बाइकार्बोनेट्स, ओनली देन, not because bicarbonate excess can lead to respiratory depression. CO2s will go up. And finally, one thing which is very important for everybody to remember is normocapnia for these patients is what is they had before exacerbation. Majority will be having high CO2 level. So do not try to normalize to 40, 45. You will end up in a trouble. So keep it around 50, 55. And also over a period of time, it will sort it out. So that is where the fineness in the medical management is needed and required.
Somebody's asked, can we use anticoagulants?
Yeah, already said it's a DVT prevention.
Sir, Dhruv sir, have you any experience of the use of the medroxyprogesterone?
Plenty. We all respiratory physicians use it. Dr. Chawla must have been using for more than what I have been
all
using.
All obese patients we always give. Particularly OHS and these patients, we always give 10 TDS.
As a physician, we have an OPD practice, and also when at the time of the discharge, if they don't do well, we use it.
Wind up now, Dr. Sanjeev.
Yes, sir. Yes, sir. Definitely, sir. Nice discussions. So I think most of the questions are already covered. So it is a good time. So my this DM student, Dr. Anup Gohatre, has presented, I think, up to mark. But definitely your questions and all the discussions will be give him a little more boosting.
Thank you.
Yes, sir. Thank you, sir.
Thank you,
Thank
sir.
you, Sanjeev.
Thank you.
Sir. Thank Thank you, Dr. Asif,
Wonderful class.
Dr. Dhruv sir, and Dr.
Thank you.
And Happy New Year, sir.
Happy New Year to each and
And
every
sir,
one of you.
आप लोग को भी
Rajesh
सर
sir,
सर
Happy
मैंने
New Year.
इसीलिए आपको विश नहीं, मैं तो आज बोलूंगा, मैं काम में पहले क्लास शुरू होगी बाद में होगी. विश यू अ वेरी हैप्पी न्यू ईयर
Thank you.
ऑल ऑफ यू.
सर थैंक यू सर, आपको भी नए साल मुबारक.
Thank you.
Thank you, sir. Thank you. Thank you,
Right.
Asif.
Thank you.
Thank
Sign
you.
off.
Okay. Okay.